Let me explain. In health impact assessments, we talk about risks, about relative risks, and about population-related risks. Let me explain what those are. Epidemiologists are interested in understanding and quantifying the health risk factors, for example, the risk of air pollution. So a very common way of quantifying the risk to develop a disease given some exposure, for example, air pollution, is the relative risk. And as the word says, it is a risk expressed in relative terms. It is the risk to develop a disease given, for example, air pollution exposure compared to the risk without that exposure. So let's make an example. Let us assume that we have an epidemiological study where we observe 2,000 people of the same age for 10 years. 1,000 of those are exposed. Let's say they are exposed to a certain level of air pollution. And the other 1,000, let's assume they are not exposed or much less exposed. So they are our comparison group. So we now watch those people and to see how many of those people develop a disease. Let's call it a lung disease. Let's call it COPD as an example. In those who are not exposed to high levels of exposure, let us assume that 50 will now develop the disease. In other words, 50 out of 1,000 or 5 in 100 will develop the disease in those not exposed. Among those exposed to high levels of air pollution, let us assume that we observe after 10 years, 150 cases. In other words, the risk to develop this disease is bigger, 150 out of 1,000 or 15 out of 100 to develop the disease. So in absolute risk terms, 15 out of 100 is this risk that might be interesting for people who live under this air pollution condition. And in absolute terms, this additional exposure has caused 10 additional cases. And these 10 cases we would attribute to air pollution. But epidemiologists like really now to compare the risks. We are less interested in these absolute risks in each group, but we like to compare them. So those with a high exposure have 15 cases out of 100, whereas those with low exposure have only 5. In other words, the exposed people, relative to the unexposed ones, they have a 3 times higher risk. And that is this magic number, the relative risk is 3 in my example. So the relative risk of developing the disease given air pollution exposure is 3. So this is a very simple number, and that's why it is used so frequently in epidemiological studies. But from a public health perspective, that value of 3, that comparative value, this risk value, is not totally useful. If our question is a different one, if our question is how important is that exposure in my population. So, in fact, we are interested in knowing how many cases in the total population can we attribute to a specific factor. And why is that interesting? It would also tell us something about the fraction of the diseases we could, at least in theory, prevent if we would remove that exposure. So let's say we are capable to remove air pollution, what would be that benefit? And that's where the population attributable risks and the population attributable fraction come in, where we are not interested anymore in this relative risk, but in fact in the risk attribution to specific cause. So it's the attributable risk, as the name already says. And that number, of course, depends on the relative risk, but the other very important factor is how many people are exposed to the risk factor. So what is the prevalence of exposure? So I made this example where we had 2,000 people. In total, we had 20 cases of the disease after 10 years, 5 in the non-exposed and 15 in the highly exposed, polluted areas. In other words, the 10 additional cases among those who are exposed would be attributable to air pollution. So 10 out of the total of 20 cases that we observe in these two populations would be attributable to air pollution, which is 50%. So that number tells us something very different, although it's still based on having a relative risk of 3. And of course, if instead of half of the population is exposed and half is not exposed, as in my example, let's say if only 10% of your population is exposed and 90% not, the attributable fraction would drastically change. In fact, with this example, the attributable fraction would go down to 16, 17%. So you see, it's this combination of relative risk with the number of people that are exposed that is ultimately relevant from a public health perspective. And there are various formulas how to combine the relative risk and the exposure. I don't want to explain those formulas, but you can find them even in textbooks and on the internet. And that's the way how you can derive it. And this is the difference between the relative individual perspective versus the population-related view on risks.